Communications with Work Care. Welcome once again to our weekly webinar on preventing and managing COVID-19 in the workplace. If this is your first time attending, we appreciate your participation, and for those of you who are loyal followers, we're glad you're back. This is our 30th consecutive week. As you know, the session is being recorded and you will be on mute during the webinar. Please submit your questions using the Q&A function in Zoom. We'll answer as many questions as we can in the time allowed, which is usually about 40 to 45 minutes, with about 10 minutes for questions. If we get a lot of questions today, some of them will be answered in writing after the webinar and posted on our website on the COVID-19 landing page. We also will be posting the recording on our YouTube channel, and Alexis will post links to those during the session. I'm going to quickly turn it over to our speaker because he has a lot to go over today. There's been so much going on related to COVID-19 in the popular media and current events with the CDC, the FDA, etc. So I'm looking forward to today's talk. Our speaker is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and our Associate Medical Director for On-Site Clinical Operations. He's also our lead clinician for our COVID-19 response. Now I'll turn it over to him. Thanks for joining us.
Excellent. Thank you, Karen, and thanks everyone to joining us again here. We're going to jump right in. If you're rejoining us, you know the format. We'll stick to that on this 7th day of October. So the introduction to our topics, clinical update, followed by pathology, microbiology, some epidemiology, prevention, and then workforce strategies. And we want to zero in today on, as Karen has spoken to, the happenings in the media. We're not going to get political, as we don't from week to week, but we do want to address some of the things that have been popularized from on high, and we want to either support or drill down into what actually is the case from a scientific standpoint in regards to some of the things that have been placed out there in the general public. So we want to make sure everyone is on the same page with what are the best strategies to move forward with your workforce and keeping your folks safe. So we'll jump right into it. In terms of the clinical update, last week we presented the depression and mental health impact as the coming second pandemic. That is continued to be supported by WHO, and they recently published here in October a report on the disruption of mental health services in most countries as a result of COVID-19. And this report is a bit disturbing in that over 60% of 60% and up to 67 percent of countries saw disruptions in counseling, psychotherapy, 65% for critical harm reduction services, and 45% for other things such as opioid management. 30%, if we jump down, reported disruptions for access for medications for mental health, neurological and substance use disorders. And then finally, around 3/4, again, 3/4, vast majority reported at least some disruption to school and workplace mental health services, and that's 78 to 75% respectively. So we know this hits home in terms of what we are seeing here in the US. We know that, as we spoke to last week, threefold increase in depression and mental health illness as a result of COVID-19 is what we've seen thus far. And we know that things are not looking rosier for the fall and for the winter months in regards to impact from a disease state from COVID-19. So we need to be vigilant in this regard. If we look at then additional clinical updates we want to be cognizant of, this study came out of Northwestern University here in Chicago, where I'm located, and to date has been perhaps the largest study looking at, in this case, over 500 patients that were hospitalized, and they examined their neurologic presentation. And the manifestations from a neurologic standpoint on these hospitalized individuals frequently included neurologic myalgias, headaches, encephalopathy, which is basically the brain swelling, if you would, dizziness, and obviously the classic symptom of anomia, which is the loss of sense of smell. And we want to also look at in this study some of the independent factors that they examined that increased risk for neurologic presentation. And one of the surprising results happened to be younger aged individuals that presented with a onset of neurologic symptoms at any point in the course of their COVID-19 infection. So that's pre-hospital as well as once they were hospitalized. So what does this mean for us? It means that the younger population aren't immune, and the younger population can and have seen increases in impact to neurologically their level of function, right? And this study is continuing in a prospective way to follow up with individuals and see what are the potential lasting deficits from a neurologic standpoint as a result of COVID-19 infection. And so we'll continue to report on this as we move forward here. So from a pathology standpoint, we want to update now on several things that are germane to vaccinations. And obviously in the news popularly, we know that the president has been affected by COVID-19. We know that he received some treatment at Walter Reed, and we want to comment on some of those items so that everyone is up to speed on where we stand on vaccinations in the U.S., availability, what treatments are being utilized and why. And we'll jump into this segment with highlighting a group called COVAX. COVAX is an organization that has been founded recently to help accelerate vaccinations globally, okay? And it's a consortium of countries that have joined together not only to help distribute and logistically ease the access to a vaccine once available, but also to focus in on partnering with those nations that have more resources to help those nations with less resources. So to date, 128 countries have signed on to this multinational agreement and effort. And if we look at those who are pending to sign on, again, a vast majority, over 2/3 of the global national footprint has been a part of this or will be a part of this effort. Unfortunately, the U.S. has not joined this effort yet, and we'll continue to pay attention to whether or not, as UN member states, we will join this effort, again, to have access here in the U.S. and to help those who need access in countries that don't have as many resources. From a standpoint of vaccination, and there's a question out there of what did President Trump get? What exactly did he have? Did he have an experimental vaccine or not? And so we want to comment on that so we can understand exactly what is in play here in the U.S. in terms of interventions to help, hopefully, one day your workforce. And so the president did not receive a vaccine or any experimental vaccine. What he did receive was a treatment from this company called Regeneron. Regeneron has had a treatment in early phase 1, phase 2 clinical trials, trying to launch into phase 3 clinical trials using what's called monoclonal antibodies, okay? Antibodies we've talked about numerous times here in the presentation. The antibodies help identify foreign antigen, meaning the SARS-CoV-2 proteins, and attack and render, hopefully, that virus unable to replicate in the human body. And so when we talk about what the president received, he received this treatment from Regeneron, which showed that in those individuals who were not hospitalized, and in particular did not have a natural response from an immune standpoint to SARS-CoV-2, there was a reduction in viral load in these individuals, okay, and showed positive trends in reducing medical visits for individuals, again, that have not been hospitalized. Now, this company is also starting to conduct studies on hospitalized individuals and whether or not their treatment can help individuals in that scenario clinically. And so if we look at what are exactly monoclonal antibodies, just to give you the background into that briefly here, we want to oversimplify its production in regards to how this particular and pharmaceuticals bring to market monoclonal antibodies. You start with an antigen, like a SARS-CoV-2 antigen protein. You introduce it to a mouse model, and then from that mouse, you extract those antibodies and place them into cells that regenerate rapidly. Plasma cells, tumor cells, called a hybridoma, finally, is what expresses those antibodies in a culture, okay? And it all stems from the same culture, cell culture, if you would, and that's what makes them monoclonal antibodies, okay? It's the same antibody produced over and over very rapidly in a controlled environment in the laboratory. And that is what President Trump received, 2 different types of monoclonal antibodies that were shown to benefit individuals by attaching and attacking, if you would, the SARS-CoV-2 virus. So now let's jump to additional things we want to talk about regarding vaccine and emergency utilizations, authorizations of vaccines, because as you know, there's continued media and pronouncement of a vaccine coming soon to the marketplace in regards to access for all of the U.S. population, right? And there's been mention of whether or not this vaccine will be available by as early as November, by Election Day, etc. So we want to comment on that so that everyone understands the most likely scenario in which a vaccine will be available. The FDA has given just recently here in October guidance for the industry, pharmaceutical industry, guidance on vaccines and how to attain emergency use authorization. In this, they specify some things that are going to lengthen the time horizon to get a vaccine on the marketplace. Specifically, that not only do a pharmaceutical need phase 1 and phase 2 data for safety and for understanding the vaccine side effects, but phase 3, which includes data on efficacy, is now necessary to the tune of 2 months worth of data. Okay, and so because of that, it will lengthen the amount of time that the leading vaccines that we've commented on here in the presentation before, from Pfizer, Moderna, etc., which are in phase 3 trials, can actually apply for an EUA. That application was expected, at least from Pfizer's CEO, in as early as the beginning of November. But again, that's going to be pushed out here a bit because of this new FDA pronouncement. And so let me go ahead and prognosticate, and this is Dr. Harris's prognostication on when likely we will have an available vaccine in the US for the general public, meaning your workforce, not military or not government agencies, but for access through distribution through work care or other clinical operations like ours. And so if we look at this from a historic standpoint and try to predict out where things will be, application for EUA, again, phase 3 clinical trials, for instance, like Pfizer, was not previously estimated until October. Now, because of FDA that we just presented on, that will be pushed out here into November to get EUA approval, for application for approval. That application process will take 30 days typically, and so we're looking at December, January for an EUA approval of a vaccine. After that, states then are allowed to place orders for the vaccines. 15 to 30 days is typically the time horizon for them to do so after an EUA approval. So now we're looking at February 2021. First administration for the US would likely begin then at some time in February 2021. But again, this not being for the general population, for a select population. FDA safety results are then captured from that initial administration in the US through this VAERS system. We won't go into that, but it's essentially how states track safety and adverse effects for vaccines. And that's a 60-day process. And so now that data collected and reported will take us out into April 2021. And then finally, we begin the mass ordering of the vaccine, up to 100 million doses. If we look again, historically, what has happened with vaccinations, early May is where that puts us. And then finally, access, for instance, with work care being able to access and distribute won't occur until mid-May. And finally, vaccinations available widely to the general public, late May, early June 2021. Again, this is best case scenario. This is if all the data that from phase 1, phase 2, and phase 3 clinical trials goes well with the leading, right now at this point, 5 leading clinical trials in phase 3. If everything goes well, this is likely going to be the timeline for a vaccine to be available. If there's any questions on that, hit me up directly. Again, that's Dr. Harris's prognostication based upon historic data for vaccine use and distribution here in the US. So let's look into the US numbers now in terms of total cases, where we stood 2 weeks ago at 6.8 million, last week at 7.1 million, and this week jumping up to 7.4 or 7.4 million cases total in the US. If we look at then the last 7 days, where these cases are emanating from, again, 2 weeks ago where we were shifting a little bit on the East Coast and Midwest, and continuing in that trend here today as we talk about the trailing 7-day average here for cases. If we look globally, India is still leading us. This is where they were leading us in terms of rates, right? Total cases, US is still #1. Rate, India is still tracking above us. The US was trending a little higher, then sustained that last week, and then this week still sustaining that trend and not decreasing in number of cases. So if we look specifically at the number, US is sitting around 40,000 cases, right, on a 7-day rolling average, whereas India is up around 89,000 to 90,000 cases. Again, one of the fastest growing cases, and they're looking to surpass us with the total number of cases here, probably in the next week or two. If we then look at deaths, again, we're going to be over the next couple of weeks paying more attention to death rates. Okay, it's been mentioned and commented on from some of our great questions that we've received through this presentation that, hey, why don't we pay more attention to the death rate? And it is important to do so. And as we approach the fall and continue to go through the fall and approach the winter months, we are expecting increasing numbers of transmissions here in the US. And one of the best ways to identify the severity of transmission and how we're doing as a nation is looking at deaths. And so as we track, we'll get more into tracking this in more detail here. We were trending downward 2 weeks ago, leveled off last week, and now in maintaining that level trend here in terms of deaths. Now, recognize that the death rate will trail the cases by about 25 to 30 days, okay? And so it will be that amount of time from today in which we're seeing these spikes in different states that we will see the spike in deaths. So we'll anticipate, and that's why we're gonna pay attention to the death rate as we move forward here more closely. As we talk about the positive cases, we're continuing that upward trend in here with the US. We continued it 2 weeks ago, last week in this depiction, and we continue it today, an upward trend of positive cases. Again, kind of a leading indicator, if you would, of how we're doing in terms of burden of disease here in the US. If we look at then the total number of cases, total number of tests that we're conducting in the U.S., still staying steady, kind of vacillating between 750,000 to right under 1 million tests on a 7-day rolling average. And so when we look at what India is doing, they have surpassed us with the number of tests that they're conducting on a daily basis. At this point, they're over 1 million tests on a daily average. So now let's talk about prevention. Let's try to figure out kind of where we're at, where we're heading, as we head into the fall. What should we expect and how do we prepare, right? Albeit that, at this point in time, a lot of you are doing great at the interventions that you're providing, the preventative services that you're providing. And so we want to make sure that we have an accurate picture of what's happening and where we're heading so that we can plan accordingly. So last week we talked briefly about what New York was doing with Mayor de Blasio and instilling a fine for individuals who were not wearing a mask in public. And we're seeing this trend happen through other states as they contemplate and have done lockdowns again to stem the tide of growing cases in the general public. And if we look then at predictions, right, we want to look at some interesting data coming from the Institute of Health Metrics and Evaluation. IHME is an organization that has been around since 2017, founded to be nonpartisan and provide data for governmental agencies on the burden of illness and disease and pandemics, epidemics, etc., mainly supported through the Bill and Melinda Gates Foundation. And so if we look at their predictions of observations of where we are now, and you can see the observed there in the orange, and then beyond that, the prediction of where we're heading in terms of number of deaths. Again, we're zeroing in on deaths because that's an important metric for how we're going to do and fare as a nation and globally. So this is global deaths. 2.3 million is what's here predicted, right? And so when we talk about the factors, easing of restrictions will balloon that well over 3 million deaths by January 2021. Coming in right under 2.5 million deaths is kind of the middle ground projection. If individuals increase their utilization of mask wearing globally, that number could drop down below 2 million to about 1.75 million deaths. Okay, and so when we look at then the margin of error, we can see that number projection can be a little bit higher and a little bit lower if we talk about the conservative approach with mask wearing. If we see the specific numbers, right, again, if we're mandating, if mandates for across the board are eased, that number being well over 3 million, current projection is 2.3 million deaths. And if we wear masks, 1.7 million deaths. So when we talk about daily deaths, we want to look at that average as a more poignant indicator on how we're doing, right? Not just total deaths. Are we trending up? Are we trending down? That's what this metric will allow us to analyze as we move forward. And so if we look at then the projection of this, 77,000 deaths a day is what's predicted, okay? 28,000 deaths if, that's if there is easing of mandates in terms of social distancing, mask wearing. If we stay on the course in terms of our policies globally, current projection is 28,000 and then 14,000 if we double down on mask wearing universally. As a side note, recently there have been CDC, the head of the CDC has come out and said, mask wearing can be maybe more effective than even a vaccine in terms of decreasing the amount of transmission, right? And certainly that is true at this point. Obviously, we don't have a vaccine, but even if and when we do, again, mask wearing is going to be the go-to way to help prevent transmission for SARS-CoV-2. If we drill in now into specific states, we want to understand which states are hotspots, right? We hear about this over and over in the media. We want to look at the data specifically. We want to see what is true, what is not true, and what trends are actually existing in each state, okay? And so if we look at, again, let's highlight deaths first. We want to look at which states are most impacted from new deaths on a daily basis, right? Texas is one of them. It's top there, over 100 new deaths. California next, followed by Florida, okay? And that does trail or track along with, for the most part, cases. If we flip over to cases here, putting them in order of greatest, we're seeing Texas having the greatest number of cases as well, Missouri, California, in terms of new cases, okay? We're not looking at total cases as much as we have in the past. We're gonna look at new deaths, we're gonna look at new cases, and we're gonna track and trend this so that, again, we're planning accordingly with our management of the workforce and what we need to do with our plans. So we want to look at, and we won't drill down into each, obviously, county at this point, but we want to get a good picture of county by county, where are we seeing increases in cases? That is depicted here in the pink and the red. And where are we seeing decreases in cases? That's depicted here in the teal, the blue colors here. If you see out on the West Coast, for the most part, things have been flat now. And why is that? One could postulate that because of the fires in California and on the West Coast, people are staying indoors and not venturing out as often and not having as many transmission opportunities because by default, they're social distancing, right? That certainly may be true. And if we look at the Midwest, deeply impacted, has collectively the highest rates here going in terms of increasing cases. And so we got to pay attention to the workforces that exist in these states so that we're identifying where we can try to bring people back and where we shouldn't bring people back because of the incidence of disease. If we look at increases in the number of COVID deaths in these states, which states have seen the greatest jumps in deaths? Again, not the total number, but the greatest jumps, rate increases of where they were before. Hawaii is leading in this number, 26 new deaths up this week. Idaho, Kansas, Wisconsin, and Iowa. And so these do correlate to what we're seeing, particularly Wisconsin, right? With lockdowns starting to happen again. And that will impact, obviously, the workforce in terms of who's allowed to keep operating in these states. So if we look at this map of the US, we can see the areas that have reopened in each state and reopening in the lighter blue, and then those who have paused, and now those states that have reversed their opening and are starting to lock down again, okay? And this is from businesses to schools, colleges across the board. And we're going to see this most likely continue to shift towards reversing those easing of restrictions and going back into a lockdown state. We'll continue to pay attention to this map so that, again, we have accurately depicted what's going on in the US and how our workforce will be impacted. So what do we do about all this, right? I mean, I'm not trying to be, preaching doom and gloom here for the foreseeable future, but it ain't looking rosy, right? And so what do we do with our workforce? Do we bring them back if they're non-essential? Can we bring them back? Should we wait and see what happens? Or should we proceed with some type of conservative approach to bringing people back safely? And obviously that's going to be an industry by industry determination. It's going to be a business determination in terms of risk. Sometimes it may not even be an option depending on what state you're in and the lockdown that may ensue in that state. But we want to give you a methodology for framing how you can understand, can I bring my workforce back, and what should I do to help? So we presented this some time ago. We revisited it a number of times, the paradigm of preventative efforts depending on the local burden of illness, right? And so we do, number one, want you to continue to focus local. And when we talk about the case rate per 100,000, that's how we presented it initially. That was when the disease was beginning and just still really getting a foothold in the US. at this point, talking about total number of cases is not as helpful. And so let's look at the rate of cases on a daily basis to understand where locally you should be okay coming back potentially with a plan in place versus an area where you should hold off and wait before you bring non-essential folk back to the workforce. So if we look at daily cases per 100,000, in general, if you're 10 in that particular county, right, this is county based, if you're 10 or less cases on a daily basis, you're kind of in that green zone, okay? I'm saying green zone not to say it's safe 100%. I'm saying green zone because consider in those areas bringing folks back, right? And having a plan in place to do so. If you're in that 25 zone there in terms of cases in the county on a daily basis per 100,000, then kind of give caution, right? Obviously, if you are leaning on the more essential workforce side, it can be considered there. If you're up in the 45 in the county daily, then I would consider not bringing the workforce back in that scenario, right? And so local numbers matter very much so in terms of where your people are located. And then step two is the plan to routine test. If the decision is, yes, we're going to bring people back, routine testing is going to be a staple for doing so safely. And we see this across the board, not just in the occupational health standpoint of the workforce, but we're seeing this in university settings, colleges that have done well to bring their students back without ballooning the incidence of transmission of COVID-19. They're doing routine testing, sometimes, most of the time weekly, sometimes multiple times a week, and even in some cases, we've talked to universities that are doing it on a daily basis. And so having that game plan, having the right test, understanding its sensitivity and specificity, and then leveraging that test on a routine basis is going to be key for bringing a workforce back successfully and safely. And so at WorkCare, we're working on solutions partnering to help you all schedule these tests so that it's taking the burden off of and the complexities of trying to get people in and get people tested on a routine basis. And this is an example of an app we're going to deploy here in the coming weeks to months. And it's just going to help you schedule and leverage your workforce for testing and send alerts, allow them to register. You can change the regimen and frequency of testing. You can change the tests that are being administered. And we partner with you to help execute on hopefully a kind of a hands-off process for you in terms of complexity of scheduling tests for your large workforces. And these alerts will tell you, hey, look, Johnny or Susie hasn't been tested on their routine schedule. It'll send an alert and allow you to reach out and say, hey, here's what's going on. Can we get you in? Can we get you tested? Again, compliance is going to be key to maintaining a safe workforce with regard to routine testing. And then step three, don't ease up, right? Don't ease up on your screening. The temperature checks, the symptomatic screening, risk stratification is essential, and it will not go away anytime soon because, as you saw, it will be well into next year before we have a vaccine in play that will grant, hopefully, the immunity at a herd level to help keep people safe and retire some of these screening protocols that we've had to have over these months. And we want to, number four, then review and revise your program return on investment. We want you to think about what are those activities that you're doing with the screening, the routine testing, the contact tracing, and the return to work process that your team is doing, and some of the things that your team should be doing, right? And to frame that, we want to look at kind of an outsourcing decision-making matrix and give you a template for that. And when you look at those activities that are strategic for your organization from a health and wellness standpoint that you want to double down on, those are things that it makes sense to keep in-house. We know that many of your organizations have had to hire new staff and new individuals to help with contact tracing, to help with the return to work process and things of that nature. But consider for the long haul, does that make sense, right? Contribution to operational performance, if done poorly, impacts negatively the business in a significant way. Consider outsourcing that if it's not a strategic alignment for your organization in general, right? And so we want you to think about this because, again, COVID ain't going anywhere anytime soon, and this is just a part of the new norm. And maintaining an in-sourced versus an outsourced strategic focus is going to be important to make sure your organization can spend resources at its most impactful in terms of keeping your workforce safe, as well as not taxing your teams to distract them from other things. We're seeing, surprisingly, an uptick in ergonomic inquiries. We're seeing an uptick, obviously, in the mental health inquiries. And these are things that also your team should be focusing in on, but you can only do so, obviously, if the right alignment for how COVID is managed is in place for the long haul. And so with that, we will stop. We will thank you for attending today, and we will open it up to questions.
Thank you, Dr. Harris. There's some questions related to some recent actions by the CDC, so we're going to jump into those first. One of them is regarding their latest update on airborne transmission. Remember, we talked about this a few weeks ago when they put up some guidance and then pulled it back down, and now they've re-released guidance again on Monday. And the question is, what precautions do you recommend an employer take given the CDC update regarding the airborne transmission of COVID?
Sure. The precautions that are in place now, right? Wearing the masks are particularly important. CDC comments on, the droplet size. We've been commenting on that for some time, the 20 micron size droplet versus the 5 micron droplet. The 5 micron droplet being more likely to be aerosolized and maintained in the air as a means of transmission, the airborne transmission, right? But again, having in place these precautions of wearing masks is going to be important. We know in certain states, employers don't have a policy of mask wearing across the board, particularly now that we're past the hot summer months. We want employers to reconsider that strongly in mandating masks use in the workplace. That will help decrease airborne transmission and decrease the rate of production of those 5 micron sized particles. And then if we talk about enclosed spaces, we mentioned way back probably, I think it was March and April, what are some of the things you can do to those enclosed spaces to help decrease transmission rate of an airborne illness? Things such as looking at your HVAC system, including HEPA filters, doing the turnover rate of the air 6 times an hour as a standard, if at all possible, are all things that will help decrease potential risks for airborne transmission. And again, the other factor is exposure duration, right? If you don't have to spend as much time in that enclosed space with a group of individuals, then that is going to be a primary way to decrease risk by decreasing actual exposure time, duration of exposure. And so and these are things, again, aligned with what CDC has come out and said, but we want to emphasize these things that we've spoken to previously as a means to help keep your workforce safe.
Okay, so there's also quite a few questions about masks related to the CDC's change from close contact within a period of 10 minutes, and now it's 15 minutes. The first question is, if 2 people are both wearing a mask and are within 6 feet of each other for 15 minutes or greater, is an exposure considered if one of those people is determined to be a positive case for COVID? Does masking make any difference, or does the close contact prevail over masking?
Sure. So the CDC doesn't specifically address, as far as I understand, that scenario, right? The precaution, the overabundance of precaution is to say, if you've been in close contact, mask or no mask, for 15 minutes or greater with an individual who is positive for COVID, then that person who has been exposed should quarantine. And so that is still the prevailing wisdom in terms of how to consider someone in a risk stratified process whether or not they should be quarantined or not, right? And there really is no other cutoff beyond that, right? In terms of, hey, I was around somebody for 20 minutes with a mask, I should be okay. No, the general guidance is if it's across that 15-minute timeline and the proximity is there, mask or no mask, you should still quarantine. And unfortunately, that's a result of not being able to verify the proper use of individuals with masks, and also the nature of these general recommendations for the non-essential workforce. Obviously, healthcare workers, since this all began, have been in close contact with COVID positive individuals for longer than 15 minutes and still maintain their presence in the workplace, right? With appropriate PPE on, N95. So if we're talking about a scenario in which your workforce is wearing a respirator like an N95, then that's a different consideration. If they've been trained to properly don and doff an N95 and they're doing so on a routine basis in the workplace, then we can consider those individuals to be non-exposed and proceed as we do in the healthcare industry to allow them to continue to work. Obviously, if they become symptomatic, then they must go home and self-isolate. But again, the cloth mask, the surgical mask don't trump the proximity and exposure level.
Okay, so there's another question about masks comparing to cellulose-based types. I'll read the question, versus face shields. Has there been any published data comparing cloth or cellulose-based masks versus a clear plastic face shield? Is it okay to equate the protection of both, or are there differences?
So I have not seen any studies that have examined cellulose-based masks versus a face shield. We know that face shields do not supplant a face mask, do not protect from the generation of potentially airborne 5-micron sized droplets. So recommendations for face shields is only to protect the mucosal membranes of the face, the eyes, the nostrils, from direct exposure to moisture from someone else's secretions. Other than that, you should be wearing some type of approved face covering like a cloth mask, multi-layered, or a surgical mask. We'll look into perhaps these cellulose-based masks, but at this point, haven't seen any studies to compare these masks and the porosity of these masks in comparison to other type of mask or face shield.
Okay, we're going to take 2 more questions. This is another prognostication type question for you. When you say that mask wearing will be the best way to prevent spread even after the vaccine is available, what does that mean in terms of how long the mask policy will be in place?
Say that one more time just to make sure I'm understanding that correctly here.
When you say, you were talking about wearing a mask being possibly more effective than the vaccine, or you were quoting a CDC official. The question is, what does that mean in terms of how long the mask policy may be in place?
Yeah, so at this point, mask policy being in place is going to be well into 2021. It won't be until we have some type of herd immunity that we'll see an easing of the mask policy, very likely. And that's just because of the primary means of transmission is respiratory droplets. And if we have a widely susceptible population, as we still will come 2021, then masks will be important for reducing those occurrences.
Okay, we can't get to all the questions today and we're out of time, but I'm going to ask one quick one, and those of you who have just submitted questions, we'll be sure to answer them in writing, so please check on our website in a day or two. We'll have it uploaded for you. The last question is about the president's treatment. The questioner wants to know why they also gave him a steroid.
Sure. So steroids are generally used for respiratory anti-inflammatory activity. So a steroid in his case would benefit how his respiratory system is reacting to the infection. And if you recall some earlier presentations we've given in the webinar, it is the host's immune response that causes the untoward outcomes in terms of disabling the respiratory system from doing its job of basically allowing you to oxygenate your blood. And so if you can decrease the inflammatory response, you can improve the function of the respiratory system and allow the individual to recover more fully. That's what, if you recall, the president had decreasing oxygen levels, again, in part because likely of the immune response of the respiratory system. Decreasing that response would improve his potential outcome, as it seems as it did in this case. And just to clarify my previous comment on cellulose masks, it wasn't inclusive of all cellulose-containing masks, such as popularized by 3M and others. I interpreted the question to speak to kind of a new effort of cellulose-based masks. So we can address that in the comments and in our FAQ subsequent to this presentation, if we can get more specific.
Okay, that would be great. Well, and regrettably, we're out of time, and we have some remaining questions, so we will get back to those and clarify that issue on the celluloid masks. So I want to thank everyone for joining us once again this week, and hope you'll all stay safe and wear your masks. Thanks, Dr. Harris.
Thank you, everyone, for attending, and we'll see you next week.